Welcome to this explainer. All right, picture this. You're on the ward and you're reviewing a 71-year-old guy who's just come in for a routine follow-up. He has heart failure with reduced ejection fraction, we're talking an EF of 30%, and he is currently optimized on a truly fantastic, life-saving 4-pillar regimen. He's taking his beta blocker, an ARNI, an SGLT2 inhibitor, and Spironolactone. Clinically, he looks great. But then, you glance at his routine morning lab work,
and boom, his potassium has come back at 5.6. Now that's a number that immediately catches your eye, right? In the busy, chaotic environment of a hospital ward or a packed outpatient clinic, a potassium level of 5.6 triggers an absolute clinical reflex. The alarms just start flashing in your head, warning you all about the risks of hyperkalemia.
So let me ask you directly, when you look at that 5.6, what is the knee-jerk reflex for you or your colleagues in this exact clinical scenario? If we're being totally honest, for decades, medical training has ingrained a very specific, almost automatic response when we see that elevated potassium level jump off a heart failure patient's chart. That reflex is almost always this: stop the spironolactone, maybe even hold the ARNI just for good measure. We pause the medications, the potassium comes down, and hey, we feel like we've solved the problem. But here is the hard truth we really need to confront in this explainer. While pausing those meds is the traditional, comfortable reflex to fix the lab number today, this exact action might actually be quietly killing the patient over the next 2 years.
Section 1. The science. The heart failure potassium paradox. Okay, let's dive into this and look at the underlying pathophysiology to understand exactly why that reflex is just so dangerous.
Here's the core scientific tension we're facing. The exact drugs that do the heavy lifting to actually improve survival in heart failure, ACE inhibitors, ARBs, ARNIs, and especially the mineralocorticoid receptor antagonists like spironolactone and eplerenone, well, they all raise serum potassium. It's not some random side effect, it's intrinsically linked to the very mechanism of how they work. To complicate things even further, our heart failure patients frequently have chronic kidney disease or diabetes layered on top, which independently jacks up their baseline risk for hyperkalemia. So the very drugs saving the patient's life naturally cause the potassium spike.
I want you to pause for a second and just consider this principle. You cannot fully separate the benefit from the risk. Let the gravity of that disease mechanic really sink in. We've got a patient population where the absolute best, most effective treatment and their biggest physiological risk factor are essentially tied to the exact same intervention. This potassium spike we're seeing, it isn't a flaw in the patient's regimen. It's actually a sign that the regimen is actively doing its job. So if we know these drugs elevate potassium, what exactly is our target? Well, this is where we need to challenge ourselves to unlearn a fundamental habit. We have to unlearn the idea that a normal lab range and an optimal range are the exact same thing. In a healthy population, sure, we might accept a fairly wide range of normal. But in heart failure, the relationship between serum potassium and mortality isn't a flat line where anything normal is totally fine. The mortality curve is actually fiercely U-shaped.
The lowest mortality risk for heart failure patients sits in an incredibly narrow, highly protective band, exactly 4.0 to 4.5 millimoles per liter. And this brilliantly illustrates the sweet spot. Searing this tight window into your memory is absolutely crucial for optimizing heart failure survival. It is definitely not the wider, more relaxed normal lab range you might be used to passively accepting. Because look at what happens when we stray from that sweet spot. Both ends of that U-shaped curve are incredibly dangerous. Dip below 4.0, and hypokalemia sharply raises the risk of ventricular arrhythmia, which is a truly terrifying concern in a population that's already highly prone to sudden cardiac death. On the flip side, most guidelines flag clinical concern for hyperkalemia starting right around 5 to 5.5, with urgent action needed above 6.0. So our job isn't just passive lab watching. It requires highly active management to keep our patients balanced right in the middle of this high-stakes tightrope.
Section 2. The real danger, stopping therapy. This brings us to the climax of the issue and the genuine risk we face on the wards every single day.
When we reflexively down-titrate or stop a RAAS inhibitor or an MRA just because of a bump in potassium, we are trading a short-term, manageable electrolyte fix for a devastating long-term mortality risk. The evidence on this is overwhelmingly consistent. Discontinuing these therapies leads to worse outcomes. And look, this isn't some rare, once-in-a-blue-moon occurrence. Real-world data shows that over a third of heart failure patients on optimal therapy will face moderate to severe hyperkalemia. It's a critical daily ward issue, meaning this dangerous reflex to stop medications is happening far, far too often.
Section 3. The modern potassium toolkit.
Let's move to and see how this builds into the modern clinical solutions we actually have at our disposal today. Because we no longer have to choose between deadly hyperkalemia and stopping life-saving drugs.
The clinical landscape has genuinely shifted. The 2022 AHA, ACC, and HFSA heart failure guidelines now give a Class 2B recommendation for the use of modern non-absorbed potassium binders. We're talking specifically about patiromer and sodium zirconium cyclosilicate. These agents are absolute game changers because they're positioned specifically to let you control the potassium levels without forcing you to sacrifice those critical RAAS inhibitor and MRA dosages.
But we do need to be clinically rigorous here. Potassium binders act as a bridge. While we know for an absolute fact that these binders effectively lower potassium and prevent recurrence, the hard outcome trials, the ones proving that using them to preserve RASI therapy directly translates to better long-term survival, those are still ongoing. Because of that, you shouldn't use a binder as a free pass to just ignore diet or worsening renal function. You use it as a bridge alongside those fundamental management strategies to keep the patient on their life-prolonging therapy.
Section 4. The Bedside Management Checklist. So how do we put this all together practically at the bedside? Let's walk through a highly actionable 4-step sequence you should automatically run in your head the second a potassium lab comes back elevated.
Step 1. Confirm the number. Hemolyzed samples falsely inflate potassium literally all the time. A simple repeat sample can save you from a completely unnecessary intervention. Step 2. Check all the drugs. Don't just tunnel vision on the cardiac meds, review NSAIDs, look for hidden supplements, and thoroughly check the renal function. Step 3. Consider binders and diet. Ask yourself, can dietary counseling or a modern potassium binder hold the line here instead of touching their heart failure meds? And finally, Step 4. Reserve down titration as an absolute last resort, strictly for genuinely severe or refractory cases. And hey, if you absolutely must reduce the dose, make an explicit, documented plan to re-challenge and up-titrate again. Do not let a temporarily held drug quietly become permanently stopped.
And a really quick reminder as we manage this, it is a two-way watch. We've got to manage both ends of that U-shaped mortality curve. A diuretic-heavy regimen used to manage fluid overload can just as easily drive a patient into dangerous hypokalemia. We are balancing on a tightrope, and we have to actively watch both sides of the net. Section 5. The callback. Back to our 71-year-old patient. Let's bring this explainer full circle and jump back to our 71-year-old man from the very beginning, sitting right in front of you with that 5.6 potassium level. So the crucial point is this. The educated, confident residence instinct is no longer to just reach for the chart and cross out the spironolactone. Instead, you confirm the number is real, you aggressively hunt for reversible causes like NSAIDs, you consider initiating a potassium binder to bring the level down safely, but above all, you actively protect the 4 pillars of his heart failure therapy unless you are truly out of all other options.
And that brings us to our final mantra. Potassium in heart failure isn't just some number to be casually normalized, it is a very narrow window to fiercely protect. Manage the potassium, don't sacrifice the therapy. So I'll leave you with this. The next time that 5.6 flashes red on your ward screen, are you going to take the easy way out, or are you ready to step up and actively protect the pillars keeping your patient alive? Thank you for joining me for this explainer.